Is it OPC? Oh, organophosphorus compound. This is very common in our country. That's why I know. Yes, like people commit suicide by taking it. Very painful. Like in the village, they are farmers. Uh, they use this compound as a pesticide. There is they got easily this thing, and it has a good smell. So people understand after taking it what they have to. Yes, it is diagnosed actually via like you will find he is vomiting, he is urinating, lots of like all secretion from everywhere, and there is pinpoint people. This pinpoint people is very important. Pinpoint people found in, as far I remember, three places like OPC, opioid, and clonidine, and cocaine, amphetamine, and TCA cause dilated people. You can remember these three. And clonidine, OPC, the three word O for opioid, O for OPC, and C for clonidine. And cat, cat has dilated pupil. I remember it like that. That's why I say cat means cocaine, amphetamine, and TCA, tricyclic antidepressant. TCA overdose, very common in the Western world. Yes. Cocaine, amphetamine, and TCA. Clonidine. Yes. Okay, OPC poisoning. Oh, sorry. These patients bradycardia. These patients bradycardia, diaphoresis, hypersalivation, meiosis. Bradycardia, diaphoresis, hypersalivation, meiosis, bronchoria with wheezing has signs of cholinergic toxicity. Most cases of cholinergic toxicity, most cases of cholinergic toxicity are due to organophosphate pesticide. However, the occurrence in multiple patients in a crowded city settings suggests intentional organophosphate exposure, possibly due to chemical weapon sarin soman. These agents have been used in multiple military and terrorist attacks. The gas is odorless, tasteless, and has a slight fruity odor. OPC inhibits cholinesterase. OPC inhibits cholinesterase in the muscarinic and nicotinic cholinergic synapses, leading to decreased acetylcholine degradation and overstimulation of the corresponding receptor, in addition to widespread increased visceral smooth muscle tone. In addition to widespread increased visceral smooth muscle tone, and glandular secretion due to muscarinic hyperactivity. And nicotinic hyperactivity causes muscle weakness and paralysis. Muscle weakness and paralysis that can lead to rapid respiratory depression and death. OPC poisoning. OPC poisoning can be confirmed with measurement of red blood cell acetylcholinesterase activity. OPC poisoning can be confirmed with the measurement of red blood cell acetylcholinesterase activity. Atropine, a competitive inhibitors of acetylcholine. Atropine, a competitive inhibitor of acetylcholine at the muscarinic receptor, can also be used for both diagnostic and treatment. The absence of anticholinergic sign, mydriasis, erythema after a small dose of atropine, 1 milligram, supports the diagnosis of OPC poisoning. Treatment usually requires much larger dose. Further management includes pralidoxime, a cholinesterase reactivating agent. A cholinesterase reactivating agent that treats both the muscarinic and the nicotinic effects of OPC. Okay. Yes. Methemoglobin levels are elevated. Methemoglobin levels are elevated in patients with methemoglobin, which typically occurs with administration of dapsone and some topical anesthetic. Methemoglobinemia happens after topical anesthetic benzocaine. Affected patients have cyanosis, dyspnea, and tachycardia. After giving anesthesia, it happened, isn't it? No, no, no. It's not malignant hyperthermia. I got wrong. Okay. It is a hypermetabolic response. Okay. This patient, this patient with severe burns now had this patient with severe burns now has persistent fever, tachycardia now, and persistent fever, tachycardia, hypertension in the absence of infection, negative blood and wound culture. Negative blood and wound culture, the most likely cause of hypermetabolic response to severe burn injury. The severity of the hypermetabolic response increases proportionally with burn size. It typically arises within 5 days of post-injury. Within 5 days of post-injury after an initial 24 to 48 hours of shock, increased capillary permeability, myocardial depression. It is likely triggered by profound release of inflammatory. It is likely triggered by profound release of inflammatory mediator from the damaged tissue, leading to increased level of catecholamine and glucocorticoid with the following clinical feature: tachycardia and hypertension due to hyperdynamic circulatory response, hyperglycemia, tachycardia, hypertension due to hyperdynamic circulatory response, hyperglycemia due to increased gluconeogenesis and insulin resistance, and elevated basal body temperature, often up to 38.5 degree, and lean mass wasting due to increased basal metabolic rate with increased protein and lipid catabolism. Strategies to attenuate the hypermetabolic response include decreasing the inflammatory source, early burn excision and grafting, blunting the catecholamine effect, beta blocker, reducing lean muscle mass, nutritional support and anabolic steroid therapy, and controlling hyperglycemia. Insulin. Severe physiologic stress. Severe burn injury can lead to adrenal insufficiency, adrenal crisis with non-specific symptom. However, hypertension is a primary manifestation of adrenal crisis. Cyanide poisoning impair aerobic metabolism and may initially cause catecholamine-mediated compensatory hypertension and tachycardia to increase oxygen delivery. However, this typically lasts. This typically lasts only minutes versus 2 days before degenerating into bradycardia and hypotension from cardiovascular toxicity. The shock wave from large explosion can cause traumatic brain injury (TBI), which may be complicated by elevated ICP. However, hypertension due to elevated ICP is classically accompanied by bradycardia and irregular respiration, Cushing thread, as well as significantly depressed global consciousness. Patient not follow commands. And malignant hyperthermia can cause fever, tachycardia, but also cause diffuse muscle rigidity versus symmetric extremity movement. In addition, it typically occurs within minutes of anesthetic agent administration versus fever lasting 48 hours. Methamphetamine intoxication rather than withdrawal cause fever, hypertension, and tachycardia due to its sympathomimetic effect. Methamphetamine withdrawal is typically characterized by depression, fatigue, and increased appetite without signs of vital sign disturbance. Yes. Common withdrawal, AB, alcohol and benzodiazepine, both causes tremor, both causes anxiety. And alcohol, there is agitation and delirium, psychosis is present. And in benzodiazepine, there may be perceptual disturbance, psychosis, and insomnia Benzos can cause insomnia, withdrawal symptom. Examination finding seizure, tachycardia, and palpitation. Seizure, tachycardia, palpitation. Opioid can cause nausea, vomiting, abdominal cramping. Opioid can cause nausea, vomiting, abdominal cramping, diarrhea, and muscle aches. Opioid can cause dilated pupil, yawning, piloerection, lacrimation, and hyperactive bowel sound. Stimulants like cocaine and amphetamine increase appetite, hypersomnia, intense psychomotor retardation, severe depression, crash. Nicotine dysphoria, irritability, anxiety, increased appetite. There is no significant finding. But cocaine and amphetamine, there is pupil dilation. They have been, sorry, yes. Okay, they are talking about withdrawal symptom. Okay, opiate withdrawal will dilate people, but opiate causes constricted cocaine. Okay, and cannabis, there is irritability, anxiety, depressed mood, insomnia, appetite. Decreased appetite. Stimulants causes increased appetite, and cannabis causes decreased appetite. Radioactive tablet. Radioactive tablet. Sorry. Is it iron? I iron is, yes, maybe. Oh, you have another thought? Okay. Look, diagnostic finding of acute iron poisoning is opaque pill on abdominal X-ray, and the little baby loves this. Little baby loves to have this iron. Okay, three. Like 3-year-old boy is brought. This 3-year-old boy actually, when they saw this iron tablet, they thought it is candy. so they start having it. You will my one of my friend, I the problem is I found the all the interesting events, and most of the interesting events actually my friends actually call me with those interesting events. One of my friends baby has ingested two magnets, and after just wasting all day in the hospital, then finally the the magnet actually fixed together, and finally it comes out through the toilet. Because you will see in one of the stem in why I am saying this, because magnet is high risk object, like like button battery. So this is high risk object, so it these magnets can cause bowel perforation. If it is fixed somewhere, it can cause bowel perforation. So you need to check via the x-ray. If it does not come out through the toilet, if it is stuck somewhere, then it can cause bowel perforation. So if it is stuck, then surgery is needed. You need to do the surgery for to remove this foreign body. There is no other option actually. Okay. These children has abdominal pain, hematemesis, and anion gap metabolic acidosis, finding consistent with acute iron poisoning. Oh, why I said this story? Because he's very upset because nothing happened. I told him to immediately go to the hospital, and he thought that it will come out. But I know that if if it stuck somewhere, it may be a huge consequence. So people loves the deadly consequence, but people don't love the normal consequence. Okay, that's what I'm talking about. Okay. Radiopaque tablets in the stomach. Radiopaque tablets in the stomach suggest an accidental ingestion of his mother's prenatal vitamin, which contain significantly uh, more iron than most vitamin preparation. Excessive iron is toxic to the GIT, causing abdominal pain, diarrhea, and bleeding, hematemesis, melena, vomitus, and stool may appear black or green from disintegrating iron tablets. Hypovolemia from gastrointestinal losses may lead to shock, a, potential complication in this patient with hypotension and and metabolic acidosis results from hydrogen ion during iron absorption and increased lactic acid production in shock. First line treatment, acute iron poisoning is aggressive volume resuscitation. Excessive iron is treated with deferoxamine, a chelating agent that binds to free iron, forming a complex that can be renally excreted. Because iron is rapidly taken up by various organs, myocardial cells, hepatocytes, deferoxamine must be administered early to the effective. Severe untreated acute iron poisoning may lead to distributive shock, systemic vasodilatation, cardiogenic shock due to iron-induced myocardial injury, hepatic necrosis, and death. Okay. It is either mm, three things are low: IgG, AM, maybe B cell deficiency. Mm, I think it's a Bruton. Oh no, it's CVID. Oof, there is a clue something. Okay, I am reading the explanation. This this patient with recurrent sinus and ear infection has low immunoglobulin level and a decreased antibody response to vaccine. Decreased antibody response to vaccine. These findings are concerning for primary humoral immunodeficiency such as CVID. CVID is caused by impaired differentiation. CVID is caused by impaired differentiation of B cell into plasma cell, which results in decreased production of various immunoglobulin. Commonly CVID commonly presents in early adulthood or adolescent with recurrent sinopulmonary infection, typically caused by encapsulated bacteria, Streptococcus pneumoniae, Haemophilus influenzae, because antibody opsonization is required for clearance of these organizations. Recurrent GIT infection can occur due to a low IgA level. In addition, patients have atopic or autoimmune conditions. Immunoglobulin profile in CVID, low IgG as well as IgG and IgM. Everything is low. Antibody response to vaccines are low. This is the important part. Antibody response to vaccines are low. Common blood count would show a very normal common blood count would show a very normal amount of white blood cell. Treatment is immunoglobulin uh, replacement therapy. Yes. X-linked gamma globulinemia. Uh, it is characterized by absent B cell production due to a defect in. Can I call you 1 minute later? My sister is calling. Okay. X-linked agammaglobulinemia is characterized by absent B cell production. It is characterized by absent B cell production due to defect in pre-B cell maturation in the bone marrow. All immunoglobulin levels all immunoglobulin levels and vaccine titers are markedly low or absent. However, presentation is typically presentation is typically in infant after maternally derived IgG whence aged 4 to 6 months. There is often a family history of male with recurrent hospitalization. Although this adolescent has ear infection as a toddler, there are common these are common in his child sorry these are common in any toddler and resolve quickly with antibiotics. Furthermore, the patient has no other infection during most of his childhood, which would be unusual for X-linked agammaglobulinemia and makes CVID more likely. Okay, for Bruton, yes. Can you differentiate these two? Yes. Classic presentation of terminal complement deficiency is Neisseria infection and immunoglobulin levels and vaccine titers should be normal because T helper cells play a role in B cell activation. Patients with T cell deficiency SCID may have decreased antibody production in addition to impaired cell mediated immunity. Unlike in these patients, severe bacterial, viral, and fungal infection would begin in this patient would begin in early infancy. LAD, leukocyte adhesion deficiency, is characterized by impaired neutrophil chemotaxis leading to frequent skin and respiratory infection. Immunoglobulin and vaccine titer would not be affected. Okay. SCID is both B and T cell. Severe, like a B cell deficiency, you can remember ABC. A for selective IgA deficiency, B for Bruton's, and C for CVID. Okay, yes. B cell deficiency are three. Yes. A, B, C. A for selective IgA deficiency. That means A deficiency. If you write A deficiency like IgA deficiency, selective IgA deficiency, um, and B for Bruton's or X-linked gamma globulin, easily Bruton's, and yes, Bruton is the same thing as X-linked. Yes, and C for CVID, and like if you want to remember like both B and T cell deficiency, it is SHAW, SHAW. Both B and T cell. So S for SCID, severe combined immunodeficiency. H for hyper IgM syndrome. A for ataxia telangiectasia, and W for Wiskott-Aldrich syndrome. H is H is hyper IgM syndrome. S is SCID, selective, sorry, severe combined immunodeficiency disease, SCID. Yes. Okay. Mm, okay. This B cell disorder. B cell disorder. B cell disorder onset is variable. Age of onset is variable, more than 4 to 6 months. More than 4 to 6 months. And key feature is encapsulated bacteria, recurrent cyanopulmonary infection, and enterovirus. IgG and vaccine response is low for B cell. Example is X-linked gamma globulin and CVID. So according to this They are saying that immunoglobulin and vaccine response is low in both cases. But so how we can differentiate these brutal they both has low immunoglobulin, but is there any difference in like vaccine titer, like low? They highlighted it. Yes, in adulthood and adolescent. Severe. Okay. So Bruton for babies and CVID for adulthood, like adolescent. You are, yes, because there is plenty of information. I need to pack it. Bruton for babies. Okay. Okay. Then next. Okay, I'm reading the box. Sorry. T cell or combined B and T cell disorder. Early, less than 4 to 6 month viral, bacterial, fungal, and infections. Candida, pneumocystis, failure to thrive, lab findings, decreased leukocyte, decreased immunoglobulin, and vaccine response. Both B and T cell is like SHAW, like severe combined immunodeficiency, hyper IgM, ataxia, telangiectasia, and viscotaltis. And only T cell is DJOR syndrome. Got it? Vis viscotaltis is Mr. Text. Always remember Mr. Text. I told you maybe once. Mr. Text, that means mutation in the WAS gene. R for recurrent infection. T for WAS gene. WAS. That means we will Wiskott Aldrich syndrome mutation. WAS gene. Mutation in the WAS gene. And R for recurrent infection. T for thrombocytopenia. E for eczema. X for X-linked. And another T for I remember it like tumor. It has increased risk of malignancy. So tumor, increased risk of autoimmune disorder and malignancy, according to the first state. Okay, and like T cell disorder, there are four T cell disorder. If you want to remember the T cell disorder, have you seen the Citadel? Citadel, Citadel is a stupid Netflix series. Okay, so CITA and Del. The first four is the mnemonic and other DL is the delete. Remember this DL is delete. That means there is nothing. Okay, C for chronic mucocutaneous candidiasis. Chronic mucocutaneous candidiasis. I for interleukin 12 receptor deficiency. T for thymic aplasia, and A for autosomal dominant hyper IgE syndrome. A, I am what I am talking about. Everything is written in the first aid. Hyper the sorry, this is hyper IgE syndrome. There is hyper IgM syndrome. There is hyper IgE syndrome, and there is no hyper IgA, but there is selective IgA. Got it? Yes. In I for interleukin 12 receptor deficiency. IL-12 receptor deficiency. In the first one, like thymic aplasia, this is this is the DJOS. Why it is called thymic aplasia? Because in this T cell disorder there is two disorder, two syndrome, like DJOS syndrome and velocardiofacial syndrome. That's why in first aid they actually separate it as thymic aplasia, because in this condition uh, you will not gonna find thymus if you do X-ray. And there is another disorder like skid. There is absence thymic shadow. So in skid there is absent thymic shadow. In thymic aplasia there is absent cardiac shadow. Okay, yes, this too is very important. That okay. Okay, phagocyte disorder. Phagocyte disorder is like in early childhood skin and soft tissue infection and fungal infection, catalase positive organism. Catalase positive organism like staph, Burkholderia, Serratia, Aspergillus nocardia. It has plenty of mnemonic. So now you don't need to jump on this mnemonic, because then you will start forgetting. Okay. In here there is CGD, chronic granulomatous disease, and leukocyte adhesion defect. And always remember the leukocyte adhesion defect in this form. Like, remember a baby is delivered, but his umbilical cord is not separated for more than 30 days or more, for more than 3 weeks. Think about LAD, leukocyte adhesion deficiency type 1. And in leukocyte adhesion deficiency you will not gonna find the pus, because leukocyte adhesion is deficient. That means there is not formation of pus. Okay, and the CGD, chronic granulomatous disease, there is two tests like dihydrorhodamine test and nitroglycerin dye reduction test. If you find these words in any stem, that is CGD, no doubt, because these two tests is nowhere present. Okay, finally the complement disorder, variable Neisseria infection and autoimmune disease, SLE. In terminal complement deficiency, like C5 to C9, increased chance of having Neisseria, and in SLE there is low C4. C3, C4 is low in SLE. Maybe C4 is low. And in C1q deficiency, there is hereditary angioedema, but it is not complement disorder. That's why it is not written here. Okay, CH50 level is low, and there is normal leukocyte and IgG.
Tell me.
As rewarming has not is as rewarming is unsuccessful, now you need to see the viability, like good doing angiography, then amputation. Okay. Okay, see the box first. Frostbite, superficial pallor and superficial pallor and anesthesia, blistering, scar formation, deep tissue necrosis, and mummification. Management is rapid rewarming, rapid rewarming in water bath, rapid rewarming in water bath. Temperature is 37 to 39 degrees Celsius. Temperature with water bath, analgesia and wound care, angiography if rewarming is unsuccessful, and thrombolysis in severe and life-threatening cases. Geography. Okay, now the explanation. This patient has hypothermia that is improving with rewarming measures, heated blankets, warm IV fluid, but left hand frostbite injury is not improving. Frostbite is caused by freezing of tissue leading to disruption of cell membrane, ischemia, vascular thrombosis, and inflammatory changes. Initial management consists of rapid rewarming. Management consists of rapid rewarming in 37 to 39 degrees Celsius water bath, which is started immediately, often accompanied by aggressive analgesia due to severe pain of rewarming. Frost-bitten skin is typically pale or grayish or hard or waxy. Thawing is considered unsuccessful. What is thawing? Thawing is considered okay. Thawing is considered successful when skin becomes red, purple, or and pliable. Failure to improve with rearming measures, persistent sensory loss, gray color may indicate continued ischemia due to vascular thrombosis. In such cases, in such cases, angiography in such cases angiography, most commonly fluoroscopic digital subtraction angiography or technetium-99 scintigraphy can help assess perfusion within the affected tissue and identify who are candidate for thrombolysis. Tissue plasminogen activator thrombolysis may improve perfusion and help salvage tissue, prevent eventual amputation of the finger when administered within 24 hours of injury. Nerve conduction study can help distinguish the cause, nerve compression of the peripheral nerve dysfunction, sensory loss in CTS. However, mm, however, they have no role in acute management of frostbite in which sensory loss is primarily due to direct injury from freezing and ischemia. So amputation, when amputation is done? Never. Okay. Some severe frostbite injury may require amputation. Some severe frostbite injury may require amputation, but initial assessment overestimates the extent of tissue damage. Amputation is not typically performed until all possible salvage and geographic thrombolysis has been exhausted and the affected tissue have been given time over weeks to months to fully demarcate. Okay, that means until unless there is a line of demarcation, so often weeks to months. Okay, so it's like a chronology, like rapid rewarming, then angiography to assess for thrombosis, then thrombolysis within 24 hours, then amputation, often weeks to months. Okay. There is no shortness of breath, isn't it? It looks like articuno, isn't it? Yes. Okay. This patient has acute urticaria intensely pruritic, well circumscribed well circumscribed erythematous plaque caused by mast cell activation in the superficial dermis, acute urticaria, Acute urticaria usually represents an IgE-mediated allergic reaction, medication, insect bite, food. Additional etiologies include infection, bacterial, viral, and systemic illness, rheumatologic disorder, mastocytosis. However, many cases are idiopathic. Initial management is Initial management is a second generation H1 blocker cetirizine a single episode such as these patients presentation typically require no additional evaluation. Lab evaluation and biopsy are recommended when urticaria is unresponsive to therapy and exhibits atypical feature purpura or is accompanied by systemic symptoms, arthritis, weight loss. Yes, intramuscular epinephrine is indicated for treatment with anaphylaxis, a severe multisystem hypersensitivity, a severe multisystem hypersensitivity reaction. Although patients with anaphylaxis may have urticaria that typically have abnormal vitals and hypertension and extradermal respiratory GI manifestation, treatment for isolated urticaria require does not require epinephrine. Yes, acute urticaria medication, insect sting. Acute urticaria medication, insect sting. Infection. Yeah. Infection, rheumatologic disease. Many cases are idiopathic mast cell release of histamine, dermal edema, pruritic erythematous plaque, wheals. Each wheel lasts less than 24 hours. Urticaria duration less than 6 weeks. Diffuse or localized, no workup or for first episode. Allergy testing if specific trigger, food is suspected, lab testing lab testing biopsy if systemic symptoms are present. Treatment is second generation H1 antihistamine and second generation H1 antihistamine and H2 antihistamine or systemic corticosteroid if severe, and two-thirds of the cases self-resolve. Okay. Okay, it's hypothermia. Though this patient is suffering from mild hypothermia. This patient is suffering from mild hypothermia, likely mild hypovolemia. Endurance athletes may be at risk for hypothermia due to cool ambient temperature, light weight clothing, excessive sweating. Characteristics features of mild hypothermia. Core body temperature 32 to 35 degrees Celsius include increased shivering, confusion, ataxia, slurred speech, tachycardia, and tachypnea. Patients with moderate hypothermia, core temperature 28 to 32 degrees Celsius, may have significant central nervous system depression along with decreased shivering, hyperventilation, hypertension, bradycardia, hypertension, bradycardia, and cardiac conduction abnormality. Severe hypothermia, core temperature less than 28 degrees Celsius, can cause marked hypertension, areflexia, coma, malignant ventricular arrhythmia, ventricular fibrillation, and significant acidosis. Most patients with mild hypothermia will respond to conservative management, include fluid resuscitation and passive rewarming, removing wet cloth and covering with blankets. Treatment should target a warming rate of approximately 1 to 2 C per hour. Core temperature may initially fall slightly due to increased return of blood from cold extremity. Once patients are euthermic, once patients are euthermic and hemodynamically stable, they may be transitions to oral fluid and nutrition. Okay, yes. Clinical features of hypothermia: mild 32 to 35 degrees Celsius, tachycardia, tachypnea, ataxia, dysarthria, increased shivering, tachycardia, tachypnea, ataxia, dysarthria, increased shivering, moderate 28 to 32 degrees Celsius, bradycardial lethargy, hypoventilation, decreased shivering, atrial arrhythmia, and severe less than 28 degrees Celsius, coma, cardiovascular collapse, ventricular arrhythmia. Treatment: general warm crystalloid for hypotension, endocardial intubation in comatose patient, rewarming technique, mild hypothermia, passive external rewarming, removing wet clothing, cover with blankets. Moderate hypothermia, active external rewarming, active external warming, warm blanket, heating pad, warm baths. And severe hypothermia, active internal rewarming, warmed pleural or peritoneal irrigation, and warm humidified oxygen. Okay. Sorry. Yes, acid fast. Nocardia is partially acid fast. Okay, this patient with cervical lymphadenitis, this patient with cervical this patient with cervical lymphadenitis, this patient with cervical lymphadenitis and nocardia, pulmonary infection within the first few months of boy's life. Within the first few months of the boy's life suggests chronic granulomatous disease (CGD), a typically X-linked recessive disorder characterized by impaired NADPH oxidase function. NADPH oxidase generates superoxide free radical in the phagolysosome of the neutrophils. As a part of oxidative burst, impaired NADPH oxidase activity allow invading bacteria and fungi to escape destruction following phagocytosis. Therefore, patients are at high risk for recurrent bacterial staphylococcal nocardia, Burkholderia capitia, and Serratia marcescens, and fungal infection. Risk is greatest with pathogens containing catalase, an enzyme that break down hydrogen peroxide as a free radical. Chronic granulomatous disease is diagnosed by measuring oxidative burst with dihydrorhodamine 1,2,3 testing, flow cytometry. Flow cytometry. mm, a flow cytometry assay that uses rhodamine derivatives that fluoresces green when oxidation occurs, normal when oxidation occurs, and a colorless if when is respiratory burst is absent. When respiratory burst is absent, that is CGD. Nocardia is partially acid-fast filamentous organism is one of the most common pathogens in patients with CGD should be suspected in the setting of capillary pneumonia. Patients are at high risk for recurrent abscesses, liver, skin, adenitis, granuloma, gastrointestinal, and genitourinary. X-linked agammaglobulinemia is marked by abnormal B cell development, leading to reduced B cell and very low serum immunoglobulin. It is typically recurrent pulmonary infection with encapsulated bacteria due to lack of opsonizing IgG. Because humoral immunity does not play a role in the control, because humoral immunity does not play a major role in the control of nocardia, nocardia infection does not typically does not play major. I don't understand the last line. No, humoral immunity does not. Sorry, nocardia is bacteria. Okay. Barcolderia, Barcolderia capacia, Monos capacia. It is CGD. Wha- Yes, because you are talking about the catalyst positive organism, and Barcolderia is another catalyst positive organism. And chronic granulomatous disease, it can cause granuloma. In the stem, there is granuloma. This shows an inflammatory reaction of granuloma formation. Okay. Oh, notoriously big bubbling hassle. Catalyst, do you want to know? Okay, I'm sending you the mnemonic. Catalyst positive. This mnemonic is a like it's a notoriously big bubbling hassle. What I have said, this is the mnemonic. Initially, I read other mnemonic, but they have changed the mnemonic. My mnemonic is my mnemonic was a previous first aid. It has written like cat need places to belch their hairball. Sorry. Yes, I sent you in the. So this is the mnemonic. And for it is also easy, notoriously big bubbling hassle because we need to remember. Look, there are two questions. Just if we know that is it catalyst positive, then our diagnosis is done. So notoriously like not nocardia, notoriously big like bordetella pertussis, bubbling is Burkholderia, and hassle is Helicobacter aspergillus, staph, Staphylococcus serratia, and Listeria E. coli. This is the catalyst positive organism. Okay. Yes. This patient has Burkholderia or Pseudomonas capacia, pneumonia, and granuloma on biopsy. Most likely has CGD. X-linked recessive immunodeficiency typically occurs in boys patients. Patients are predisposed primarily to recurrent lung infection, pneumonia, empyema, hilal adenopathy, abscess, skin, liver, lymph node. Perirectal infection is common. The pathogenesis of the CJD involves NADPH oxidase. This enzyme is normally responsible for the neutrophil respiratory burst, a process in which reactive oxygen species superoxide radical hydrogen peroxide are formed lysosomal and activate lysosomal proteases involved in pathogen destruction. Patients with CGD have mutations in the NADPH oxidase and therefore decreased production of superoxide anions. Although neutrophils may use hydrogen peroxidase production by pathogens, Organisms that produce catalase can degrade their own reactive oxygen species, and therefore infection with CGD are typically due to catalase positive bacteria and fungi, staph, Burkholderia, Nocardia, Aspergillus. Patients with CGD often develop characteristic granulomas seen in this boy that can involve many organ system, GIT, urinary tract, lungs. The pathogenesis likely involve migration of phagocytes to infection site, but migration of the pathogens to the infection site, but inability to degrade the inflammatory signal and invading organism. This leads to a chronic and focal aggregation and inflammatory cells or granuloma. Okay, do you want me to read the box? Okay, okay. Viscous is not the B and T cell disorder. In here, uh, Viscous Ulrich is B and both B and T cell disorder. In here, important is IgM is higher, hyper IgM is high, and the second one CD4 CD8 ratio like B cell is normal. CD4 CD8 ratio CD4 CD8 ratio, it indicates actually B and T cell both, but it is normal. Okay, although frequent mild respiratory infection common in childhood, this patient has severe recurrent sinopulmonary infection leading to intubation. leading to intubation membrane perforation leading to intubation, membrane perforation, and pore growth. These findings are concerning for primary immunodeficiency in the setting of low I, in the setting of low IgA and IgG, low IgA and low IgA and IgG, and markedly elevated IgM is the most likely cause of hyper IgM syndrome. Hyper IgM is an X-linked recessive defect CD40 ligand which is normally present on T cell, which is normally present on T cell that binds to the CD40, that binds to the CD40 on B cell, that binds to the CD40 on T cell. Um, this interaction induces immunological class switching in which B cell that normally express only IgM isotype can produce other isotype IgG, IgA deficiency of CD40 ligand in hyper IgM syndrome. Deficiency of CD40 ligand in hyper IgM syndrome prevents class switching, leading to elevated IgM level and deficiency of all other immunoglobulin types. Although they are dysfunctional, B and T cell concentrations are normal. Lymphocytosis can occur during active infection and neutropenia, as in this patient. Okay, lymphocyte count is high, 75, and neutrophilia, lymphocytosis, and neutropenia. Hyper IgM syndrome generally presents in infancy with recurrent sinopulmonary infection caused by encapsulated bacteria due to lack of option in IgG. Patients also have frequent viral infections as increased risk of opportunistic infection, pneumocystis pneumonia, reflecting T cell interaction T cell interaction with antigen presenting cell growth impairment can result from high energy expenditure and intake of poor intake during illness. Treatment includes antibiotic prophylaxis and IVIG. Okay. Yes. In selective IgA deficiency, IgA is low and everything from B cell to game, everything is normal. Remember the B cells game. So B cells game is normal except IgA is low. In Job syndrome, IgE is higher and the game is normal. Okay, the B game is normal. And CD40 ligand deficiency, hyper IgM. In hyper IgM syndrome, B cell is normal and hyper IgM is higher and everyone is low, like IgAE is low. So in CD40 ligand deficiency, B cell count is normal and hyper IgM is higher and GAE is low. And in CVID, B cell is normal and the game is low. And in X-link, B game is low. All the B cell is low and the game is low. Okay. Yes. Okay. Yes, it's problematic. I know.